All right, I'll put you guys in. Would you please like everyone, please Zoe Harris, you come up, get project on Chicago. Hello, everyone, my name is Zoe Harris, I'm a citizen of the Maxwell tribe, and I currently live here on Three Parcel Land in Chicago. I'm so excited to have everybody here today. So the panel for this afternoon, I suppose, is going to be Native Healthcare, past, present, and future. And we are so happy to have all of our co-sponsors, the College of Life Health Sciences, College of Pharmacy, College of Medicine, School of Public Health, and this is a collaboration between the Indigenous Graduate Student Association, which is a new student organization here on campus, as well as the health program. So again, we're really excited to have you here today. To start, we're just going to do a really quick keynote from Dr. Sandy Murray, who is the Senior Manager of Utilization Management within Specialty Clinical Development at CVS Caremark. She is a Ojibwe, Chippewa, and a registered member of the Tomahawk Bay Indian Community in Aranda, Michigan. Dr. Mara is a UIC College of Pharmacy graduate and has worked for CVS Health for 21 years. She has also worked in other roles, including being a clinical pharmacist and clinical trial coordinator for NIH clinical trials for pediatric HIV, Bury Children's Hospital, formerly Children's Memorial Hospital. Dr. Mara completed her junior co-step internship with the Indian Health Services at Lawton, Oklahoma Indian Hospital, and her clerkship at an Indian Health Service clinic in Shanto, Arizona. Dr. Mara is a current member of the UIC Urban Health Community Advisory Council and a previous recipient of the UIC Urban Health Program Trailblazer Column. So, Dr. Terry.
Thank you for that introduction, Zoe, and organizing this wonderful event. Before I begin my discussion, I just want to take a moment to say it feels great being back here on campus. I received my PharmD here at UIC in 1999. Walking into this building was very nostalgic. It brings that feeling of excitement and ambition that I had over 25 years ago. I can remember the first day in pharmacy school in 1995. Walking in and feeling like, wow, I made it, even though it was really just my first day of school. Me, a Native girl from a low-income community on the northwest side of Chicago, and the first in my family to attend college. In my mind, I had beat the odds already, and now I was going to be working towards my doctorate. Something that gave me comfort and confidence on that first day was I was welcomed by Dr. Awe and members of the Urban Health Program. Did I say something? Okay. Welcome by Dr. Awe and members of the Urban Health Program. And that offered me encouragement and support that I needed and that I was lacking in my personal surroundings. So I am so excited about the development of the Indigenous Graduate Student Association, the ongoing efforts of the recruitment and retention of Indigenous undergraduates, and especially the work of the Urban Health Program for offering hope and giving confidence to underrepresented students. I'm proud to be leading this discussion today, now as a member of the Urban Health Community Advisory Council, and being able to speak on this very important topic of healthcare and the challenges facing Native American communities. So let's begin with looking at some facts. According to the Centers of Disease Control and Prevention, life expectancy of Native Americans and Alaskan Natives is 5.5 years less than all races in the US population. They continue to die at higher rates than other Americans in many categories, including chronic liver disease, cirrhosis, chronic lower respiratory disease, and diabetes mellitus. Native Americans are actually twice as likely as whites to have diabetes. More recently, the COVID-19 pandemic disproportionately affected the Native population, having infection rates of over 3.5 times higher, being 4 times more likely to be hospitalized as a result of COVID, and having higher rates of mortality at younger age than non-Hispanic whites. Natives also experience a disproportionately higher rate of mental health and behavioral health challenges compared to other populations. Native communities experience higher rate of suicide, substance abuse, depression, unemployment, and poverty. Now, though these statistics are astonishing, I think it's even more disheartening that these statistics are not well known and rarely acknowledged. I myself was unaware of these disparities facing our Native communities well until my adulthood. In the summer of 1997, I had the opportunity to work for the Indian Health Service through the Junior Co-Step internship. I was stationed in Lawton, Oklahoma at the Lawton Indian Hospital. Lawton is located on the southwest Oklahoma, where approximately 25,000 members of the Caddo, Comanche, Delaware, Apache, Fort Sill Apache, Kiowa, and Wichita tribes are concentrated. On my first day, my boss had sent me across campus to fill out the mounds of paperwork that comes with government internships. Those of you who might be familiar. I can remember walking into the building, two Native women walking through the elevator with me. So I'm there waiting, and one of the Native women says to the other one, "Man, I'm so tired today, diabetes." And then the other woman was like, "Yeah." She's like, "Oh, I don't have diabetes." And then the first woman was like, "What? Like, you don't have diabetes? Wow, you're so lucky. You're one of the lucky ones." And, that was my first thing. I was thinking about that. I was like, wow, here it's more common for everybody, to have diabetes rather than not. And that was like very impactful to me. And I remember that even to this day, thinking that that was the first time I think I truly realized the disparities that Native Americans have in health. So my experience with the Indian Health Service was very enlightening. For those who may not be familiar, the Indian Health Service is an agency within the U.S. Department of Health and Human Services that provides care to over 2.2 million Native Americans across the country. Although IHS fulfills treaty responsibilities to provide health care for members of more than 560 recognized tribes, Congress has consistently underfunded the agency, forcing hospital administrators to limit services that they offer. As a result, tribal members have a very different healthcare reality than most other residents in the United States. I was able to witness this firsthand in my internship in Oklahoma, as I mentioned, but I think more so during my pharmacy clerkships, where I was stationed in Shanto, Arizona. Shanto is located in a very remote area, and it's the westernmost part of Navajo Nation. The clinic there serves approximately 7,000 nearby residents, yet it was only staffed with 2 physicians and 2 nurse practitioners. One day I was asked by one of the nurses if I would like to join her for some home visits. We drove through the desolate desert area into a small hogan. Yes, even then in like the late 90s, people were still living in hogans, which are 1-room like dwellings there in Arizona. The woman was there, lived there with her 1 son. She was a 1-leg amputee, nearly blind, and suffering from diabetes and heart disease. Her home had no running water or electricity. And I felt like as if I had traveled to the third world country, that I could not believe that natives were living with these living conditions in the 20th century. But it was a great experience to see the native nurse there. And even though she didn't speak Navajo, the son spoke both and was able to translate. And she took just such special care in caring for this woman and trying to see if there's any resources that she can bring from the clinic to help the patient out. So I applaud the dedication of the healthcare workers in IHS and the efforts that they put forth to care for Native people. As a matter of fact, during my internships, I viewed the operations of IHS pharmacy as very progressive. I was in pharmacy school at the time before pharmacists could provide many direct patient care services that they do today. We could not immunize, we weren't getting reimbursed for MTM services, and we did not have prescribing power. However, the pharmacists in IHS were reading chart notes, prescribing medications, making appropriate medication substitution, and counseling every patient on their medication. I soon came to realize that this innovative healthcare practice came more out of necessity due to lack of resources. Nonetheless, it was great to be part of this cross-functional collaboration of care at a time before the mainstream healthcare community really recognized the positive impact that clinical pharmacists could make in patient care. So addressing health disparities in Native American communities will require us to have a greater understanding of the many factors that influence health statistics. The U.S. Department of Health and Human Services has defined these factors as the social determinants of health. Broadly, they fall into 5 different categories: economic stability, education, social community settings, health, and healthcare in the neighborhoods and environments. So impacting these factors will take a combined effort through government, education, and community leadership. And this is where we come in. We need to encourage, first and foremost, our government to provide adequate funding that supports evidence-based, outcome-based, and community-based solutions. The U.S. government has a moral and legal responsibility to address the crisis in health equity. A strong investment in public health, illness prevention, technology, and recruitment of highly skilled providers is essential to positively impacting overall Native health. Providing larger scholarships and loan repayment programs could also help to attract a greater pipeline of health professionals to serve in tribal communities. Increasing the number of providers, however, is not all that's needed. Physicians with knowledge of sensitivity to the traditions of Native communities can help greatly improve healthcare outcomes. Having familiarity with the cultural values, lifestyles, and spiritual beliefs of a patient can enhance a doctor-patient relationship. Indigenous populations experience some of the most dramatic health disparities, yet few medical schools equip students with the skills to address these inequities. Developing an Indigenous health curriculum, as one currently in development at the University of Minnesota Duluth, can prepare students to work effectively with the Indigenous populations. Additionally, finding strategies to increase the number of Native American and Alaska Natives in medicine is imperative. Given the low number of Natives enrolled in medical schools, positive examples and role models are sorely needed. Native students have a history of feeling like universities aren't for them and doubt their ability to pursue some of the careers because they frankly don't see themselves in those careers. However, when a young person can see a Native doctor, a Native nurse, a Native pharmacist, a Native PA, it allows them to envision themselves in the same position. The recruiting efforts to attract Native students to careers in healthcare at an early age and creating a balanced pathway between the 2-year tribal colleges and 4-year institutions can help better to bridge this gap. Lastly, there's a need to focus on health promotion and disease prevention for Native Americans. Providing accurate and culturally tailored health information has been shown to influence health behaviors and health outcomes. There needs to be a call to action for the development, implementation, and evaluation of culturally relevant health promotion programs in tribes, and especially to our elders. Lone Man Isalawika Tenten Sioux once said, "I have seen that in any great undertaking, it is not enough for a man to depend simply upon himself. I believe now is the time of a great undertaking, and I'm glad that we have one another to depend on." Thank you for having me here today. It's been an honor to lead this discussion, and I'm looking very forward to the next part of our program to hear from an amazing panel of Native professionals and community leaders. Thank you.
Thank you so much, Dr. Morrow, especially work through our technical difficulties. But yes, like you said, I am very excited to introduce our panelists. So all of them have very amazing bios, and I want to talk. I'm going to say all of it because they're really doing amazing work and have been doing amazing work. So on the end, we have Roxanne and Lavelle Navia, who is the Executive Director of the American Indian Health Service of Chicago. As an enrolled member of the Turtle Mountain Band of Chippewa, she attended Concordia College in Moorhead, Minnesota, undergrad, and is a graduate of the University of North Dakota School of Law. Throughout her career, she has worked in many areas in the United States, looking directly to health disparities that exist in many tribal areas. She worked in Alaska areas in the Health Service, Great Plains region, Billings, Aberdeen, and Bemidji areas. Indian Health Service and Indian Health Service headquarters. In her roles within the Indian Health Service HQ, she oversaw grant management, PEO and diversity, regulatory and policy coordination, physician, administrative and emergency services, asset management, HR, Commission Corps Personal Office, and personnel security and office policy. She also works as a chief executive officer of the Plan R. Burdick Memorial Health Care Facility in our hometown of Belfort, North Dakota. UMB MHCF has an inpatient hospital with 32 beds, outpatient clinic, OBGYN, surgery, dental, pharmacy, podiatry, optometry, behavioral health, physical therapy, radiology, CT X-ray, and mobile MRI, 24-hour ER, behavioral health, physical therapy, radiology, laboratory services, which serves over 14,000. Currently, the American Indian Health Service of Chicago offers basic clinical services, diabetes care, 340B pharmacy, behavioral health counseling and testing, alcohol and substance abuse treatment, public health nursing, and coverage services. And as they continue to provide services to a patient population, they continue to grow their services often as well. They also offer talking circles for various groups within the community, as well as group traditional teaching. So, Roxanne, next we have Alex Peterson. Alex is a third-year medicine student and IHS scholarship recipient here at the University of Illinois, Chicago. He's a member of the Hopi tribe and is originally from rural Arizona. He first finished undergrad at the University of Arizona. Alex worked in the Venezuela lab, NIH, and AIT in Maryland, researching the West media, parasite, and exactly the same plot. Currently, Alex has been involved with the Association of Native American Medical Students locally and nationally, previously serving as a member at large on the national board and helping found the local university. His efforts have helped increase Indigenous visibility here at UIC and have resulted in in-state tuition for American Indian, Alaska Native here at the College of Medicine. Alex hopes to become a family medical practitioner focusing on community health, health disparities, and Indigenous health poverty. Next, we have Crystal Gomez, who is a member of the Passamaquoddy tribe of Arizona. She was born in Chicago and spent half of her childhood in West Elton neighborhood on the southwest side of the city. The English half of her language is too from Arizona. She graduated from the University of Arizona in 2013 with her BS in microbiology and shortly after moved back to Chicago. During that time, she had hoped to pursue medical school, but while working at Northwestern Medicine, she realized her passion lied elsewhere. After years of putting off continued education, the pandemic and her current role as a clinical research coordinator made her realize there's no better time than the present. She applied to the University of North Dakota, where she's working towards a master's in public health with a focus on Indigenous health. Inspired by her Indigenous health coursework, she knew there was still more to do. So she started retaking the prerequisites for nursing school, and here she is today, a first-year nursing student here at the University of Illinois in the Advanced Generalist Master's. She hopes to continue on to the GNP program and return to Arizona to work with her tribe and many tribes that reside in the Southwest. Here we have Crystal, and then last but certainly not least, we have Dr. Angela Walden, who's a citizen of the Cherokee Nation and is the Assistant Vice Chancellor for Diversity Initiatives in the Office of the Vice Chancellor for Diversity, Equity, and Engagement, and faculty in the Department of Psychology here at the University of Illinois. Her primary role at the university is directing UIC's postdoctoral scholar, the Faculty Pipeline Program, the Bridge to Faculty Scholars Program. The program aims to recruit and retain historically excluded and underrepresented scholars to the university. Angela also created and leads the Office of Diversity, Equity, and Engagement, Native American and Indigenous Inclusion and Belonging Initiative, which recently launched an education campaign called Acknowledge as a Verb that utilizes growing interest in land acknowledgement practices as an entry point for increasing campus-wide knowledge about Native American and Indigenous communities and building support for Native American and Indigenous students, staff, and faculty at UIC. Angela continues to collaborate on research examining the responsiveness of systems to marginalized and minoritized communities. She received her Bachelor of Science degree in psychology from California Polytechnic State University and Matthew Hart a doctoral degree in clinical community psychology from the University of Illinois Urbana. to complete her clinical internship and postdoctoral training at the Institute for Juvenile Research at the University of Illinois. Dr. Nicole Walden, just give a quick round of applause to our panel. So, as we get into our panel, I'll ask you questions, but sometimes I'll specifically ask you to, because there's a lot of this panel, but the first question I want to ask, and I would love for all of you to answer it, is when you think of Native healthcare, what comes to mind?
Okay, this is Roxanne. The first thing that comes to mind for me. Don't get sick after June. The reason for that is because of IHS funding. After a certain period of time, funding gets spent. So from June until after October, Indian health clinics and urban health programs aren't funded. And so the funding has went out by that time, so if you're on the reservation, you need to be referred out. It's not gonna happen unless it's a life or death emergency.
So yeah, when I think of Native healthcare, a lot of times we talk about it like in academia and in a political sense as the interface of Native American indigenous people here in America interface with Western United States healthcare policy and such. Like in more general terms, like Native health is a different thing in that like our Native, like our traditions and our heritage have a more encompassing perspective of what health is and what wellness is, that is rooted in our traditions. But unfortunately, a lot of these traditions have been eroded away due to colonization. So yeah, when I think of Native healthcare, I think of the interface that is very poorly maintained between U.S. policy and our Native populations.
When I think of Native healthcare, I think of very open. And for a few reasons. So my tribe in the 70s opted out of the Green Health Services, so I have personally never used IHS healthcare. We opted out and contracted with El Rio in Tucson, which is like lower income clinic. So variation in that sense, there's also urban Indian health programs. Also the type of care you get, so how soon it takes you to see a clinician. I didn't know it was different. I assumed that everyone who wanted to see a clinician had to 8 months to get that healthcare. And then when I moved to Chicago after I graduated, and I remember I had like a sinus infection once, I called, found a PCP, and they got me in that afternoon, and my mind was blown. I didn't know that was a thing that people could actually do. So yeah, I think it's very interesting.
And I would just, since I'm going last and answering this question, I have the benefit of saying, I'd like to echo everything that my fellow panelists have said. And two things kind of come to mind. One is a personal experience. So I grew up in Oklahoma, between Oklahoma City and the northeastern corner of the state, Cherokee Territory. And in the mid-90s, my father got ill and had to go to the hospital, went to an IHS hospital. And I remember I must have been about 11 or 12, just how different that hospital was in terms of walking in and seeing how long it took for him to be seen, the condition of that particular hospital and the equipment. It was, even as a child, it was very clear to me that this was a very under-resourced setting. But the other thing that really comes to mind, and I just want to echo Roxanne, what you said about the IHS, the health budget. I think one thing that always comes up for me, and this is probably why I'm a psychologist, is representation of Native people. and what people in the broader mainstream US society think of when they think of a Native person. And how that usually is a historical, I've even heard people say that they don't realize that Native people exist currently, or if they exist, they think of them only as based on reservation land. And we know that that's just not the case, but those misperceptions shape policy, and that deeply shapes how resources are decided upon and allocated. And so for me, it always comes back to sort of these just prevalent misunderstandings about Native people and how that can really affect our health in these meaningful, real ways.
Thank you all so much for that framing. Kind of relates to that question, I think, Alex, you brought this up a little bit, talking about how all these different aspects of health, that how is Native healthcare different from other types of healthcare? Whether that's just thinking about ambulatory care, just what makes it Native healthcare?
So I approach native healthcare in quotations as, again, like it's this interface between like treating our native populations with this Western medicine that and this Western healthcare system that originated from the 1800s. And it doesn't fully serve the needs of our population in terms of both having the resources for adequate healthcare in comparison to the rest of the United States, and also in terms of us being indigenous, in terms of our spiritual well-being and our historical practices of health and wellness. Does that answer your question?
Yeah. And then I would also say, Roxanne, how does what you do in the clinic, what makes it culturally relevant to Native populations compared to when somebody walks into, the UI Health or a John Stroker?
When people walk into our clinic, when you walk into the clinic side, the first thing you see as you enter the building is you notice on all the windows, we have, whether it's American Indian Health, we have like currently, I think it's still the Every Child Matters slides that are up. Depending on what season, what is going on, we always make sure our exterior work reflects what is current in the Native community at that time. We also do big events for NMLW. We make sure that we stay on top of issues that are currently hot topics within the Native community. And as you enter the doorway, you'll see like Boozhoo, which is all of the greetings in different Native languages are on the wall as you enter. And as you then go to the waiting room, you'll see that there's Native artwork. And we have, a Native person who's at registration on both our clinical side and our behavioral health side, as well as trying to recruit and encourage Native practitioners, advanced practitioners to come back, work within their community for positions which are difficult to find natives in, such as MDs, nurse practitioners, nursing even in this area. We try to recruit natives where we can find them and to make people feel more comfortable, but everyone who is on staff is very devoted to the Native culture, and they actually spend time learning. And so they spend time with our cultural mentors. They actually know, if people aren't looking you in the eye, that doesn't mean that they're disrespectful or they're being invasive. It just means that it was what they were taught by their families as a method of showing respect. Even though they may be older than the provider, they're still showing that respect because of that person's role in the community. And so that's part of what we do. And we also have cultural programs that go on in the clinic as well. And we're just really trying to create that balance of healing the whole person, not just the physical or behavioral health ailments.
Thank you so much. Roxanne. So again, I'll ask you all to just briefly describe the native populations that you currently work with or have worked with in the past, just to kind of give the people in the room, the people online, what native health, what the populations that we're starting to look like. Want to go first, Angela?
Well, yeah, I'll be brief, in fact, because, so I have moved out of the faculty role as of about 3 years ago. And prior to that, I was doing, mostly research, but a little bit of clinical work with our, adolescent and child clinic. And, I gotta be really honest with you, I didn't really see any native families at all. And I think that that's something that many clinics and spaces where people are seeing that are kind of more mainstream clinic spaces, could do more outreach and coordination efforts to increase our patient population, at the same time recognizing that we need to do that when we are ready to adequately serve those community members. So, my hands-on experience in terms of providing direct services to Native folks is actually quite limited. A lot of what I have spent my time doing, both as a graduate student when I was in Champaign-Urbana, and since I came to UIC, I've been doing the same thing, is trying to help our university community members at all levels, students, faculty, staff, leaders, to understand that Native people are everywhere. And especially in Chicago, this is a large Native community that lives in the city. And helping just get people on board with understanding some basic things about Native folks, and some recommendations for what we should be doing institutionally to be more supportive and better serve our community.
So for me right now, I don't work with anyone in the Indigenous community. My population is Indigenous, so GBM. So that's something that I'm working on right now. As an undergrad, I did spend a lot of time at the University of Arizona, working with the College of Medicine and recruiting students to healthcare professions. And I worked on the reservation as a lifeguard. I did a lot of EMT shadowing, just so I could do the ride along and kind of get gauge what the issues were on my reservation. But since I've been in Chicago, I haven't done as much work as I'd like to, but I feel like this might be a good place to make those connections so that I can get back into it.
So for myself, during my undergraduate, I did research with the Native American Cancer Prevention group that was a collaboration between the University of Arizona and Northern Arizona University. So I was able to do a good amount of research and researching various types of cancer that our Native people in the Southwest experience, namely various forms of GI cancer, which are not as common in other populations due to the uranium mining in Arizona and New Mexico, and the coal mining as well, led to increased levels of arsenic in Navajo and Hopi groundwater and our water sources. So I did that, and then I've also worked with the Hopi Cancer Prevention Association or something. I can't remember the exact title of the organization, but I also did work with them during my undergraduate and while in med school. I haven't had the opportunity to work as a provider as much for our Native community here, but I was able to spend some time up in Minnesota in the Bemidji area working at one of their IHS hospitals.
This is fun question thing. I, of course, have worked in an urban study currently within Chicago. I also worked in the urban study in Cambridge, which was privately run level 1 trauma hospital. I worked in the area office of the Alaska Native Medical Center. And so that was a fantastic experience because it showed me what tribes are able to do with the limited funding that they receive. And after Alaska had 638, which is a term non-Indians really don't understand what that means, is that tribes have opted to take their federal funds and use them in a way that serves them, and it's called, self-governance and that government to government relationship. And, it's something that we haven't talked about yet as part of this panel, but, just to share with people who are watching, government to government relationships are treated. And we are supposed to be consulted when it comes to funding and how IHS allocates funding. I was actually just up in Green Bay for the Comanche area budget allocation meeting. And that is part of that government to government relations. As I was there representing Chicago Urban, but all of the tribes from Wisconsin, Michigan, Minnesota were all present and have a say in how funding is allocated and what the priorities are for the Comanche region. And this is done in each of the 13 regions that IHS has. So we actually have a voice in how that limited funding that IHS receives is spent. But when you look at the allocation that IHS receives, it's less than Medicare, Medicaid services. It's less than the VA, it's less than the Bureau of Prisons. All of these groups are funded at much higher levels than the Indian Health Service. And so this brings me back to, I've also worked on reservations. I worked on my home reservation, which is the Turtle Mountains. And we actually have, I think there are over 40,000 tribal members, of which 14,000 reside directly on the reservation. And so that means the rest are scattered from Barrow down to Key West, Florida. And so the tribe is very scattered in part of this because of relocation, which is how a lot of it is wound up in urban areas and suburban areas. So I've worked across the spectrum, and as each panelist has spoken, I have connections with each of them, even though we don't know it. And within the Native community, that's very common. It's like as you work within the Native community, you always meet people who you know personally. So instead of being 5 steps of separation, it's normally 1 or 2.
Yeah, I am originally from the East Coast, and within a week of being in Chicago, and my kids are like, oh, I know this person, because I was like, I can't escape you. All that to say, so as you all said, we're all living in an urban environment right now. I think contrary to popular belief, 70% of Native people live in urban environments. So with that being said, can you talk a little bit more about how healthcare here in Chicago compares to healthcare in more rural environments, whether that's through your own personal experience, and now at the beginning, a lot of Angela, you were talking about your grandfather in Oklahoma, Roxanne, your work with your own tribal community. So how does being on the reservation compare to these urban environments, even though, like you said, there's really not that much representation, even though most Native people live in these urban environments?
Sure. Yes, there's a lot in that question, but it's a great question. And so there are a couple things that I want to highlight from my personal experience that I think are illustrations of bigger patterns. So when I came to Chicago and was engaged in research, I was told by a colleague who was here at the time, moved to a different institution, that I would have to have, if I wanted to do any research with Native communities, that I would have to have 2 lines of research. I would have to have one that, I could collaborate more readily with people in my department. And then I could carve out native research as another line. And to put that into context a little bit, that, like a lot of times in academia, we are really trained to think about being very specific and kind of carving out a specific single line of research that you can delve deeper and deeper into. And when you are trying to carve out two sorts of areas of research, that's a lot of work. And I think some of that recommendation came from the fact that over and over again, I've encountered very supportive, very lovely colleagues and folks that I've met since being in Chicago, who also have no sense that Native people exist in Chicago and have no sense that sense of sort of how fundable Native research is, it turns out, especially in health. So, for example, the National Institutes of Health, there are institutes within that umbrella that have whole portfolios that are just about Native American research and health. NIDA is a huge funder of Native American health research, for example. And so the sense that I got from folks that this wasn't fundable or I didn't kind of do that once I got it, I could do Native research once I got it established, I think is there's some truth in that because I do need colleagues who are interested and can collaborate, but it's not true that that work is not fundable or not very important in terms of having a chance to have a major impact. So, again, I think for me, I sort of like march in the same line of thinking about how important it is to have representation of Native people as they are now, to really have our colleagues and allies gain a better understanding of contemporary Native American people, to understand that this is a political identity in addition to being potentially a race and ethnicity category. So people often will say, and I'm sure folks on this panel have heard it before, like you might encounter folks who say, I didn't know there were Native people, I've never met a Native person, or oh, you don't look like a Native person to me. And I think it's because it's those ingrained stereotypes that keep people from seeing us for how we are. And again, that just affects everything. It affects how we set up our systems. It affects how people value things in those systems. It affects what gets funded. It affects how it gets funded. All of that is important. Hopefully that makes sense. Yeah, I think. Circular alchemy,
Yeah, so the question to repeat was like the difference or similarities you see between rural and urban.
Yeah.
Well, so I think the research has actually shown that urban natives actually experience worse health outcomes than a lot of rural natives. And I think a lot of this is due in part to, there just not being the urban resources out there for them as much as like, well, you on the reservation, you have your NHS clinic, and you can go to them, and while they're poorly funded and have a lot of issues with them, there's somewhere you can go for your help. But as for similarities, at least in my experience, I've seen the same thing over and over again. You have a high turnover of medical personnel. Like I haven't had the same doctor ever, because usually you go to a clinic and you see a doctor, and then the next, like within the next 3 years, whatever, they leave because they've paid off their health service commitment. And you continue to see like just limited funding, limited resources, and also limited reach in not only the rural communities. Yeah, there's communities that have a hard time accessing even the facilities out in their direction. And here, even in Chicago, we have a health center, but like it's up in the north side. And we know that like the Native population here in Chicago is pretty spread out through Chicago. There's a north side community, and there's also like a pretty strong south side community. But how do people on the south side reach those services? it's pretty hard, especially if you don't have good access to like personal transport.
Yeah.
Yeah, I was gonna say that same thing, 'cause growing up, I don't think I ever saw the same provider more than once. It was always a new person, someone that was doing a rotation through, the residency program, checking off a box. He was only there for a few months at a time, maybe 6 months at most. A lot of aggression, a lot of stereotypes that even I noticed when I was younger, that I pick up on. A lot of assumptions that were made about me, as a young woman. And coming here to Chicago, I've had 2 PCPs. The first one, I did love her. She listened great. The one I have right now, she's amazing. I know my chart is the thing here. It's nothing on through any Indian health service that I know of. So it's easily accessible to get a hold of your PCP, not them and their nurse. So it's just that access, and I think I've lucked out with my PCP that she's also, she's African American, and she's able to see past a lot of things. Like, I have very honest conversations with her. And she listens, and I think that's something that is really hard to find. Even in this era of like cultural competency and cultural safety, it is very hard to find someone that actually practices it very well.
In comparison, I would say that within the urban setting, we have a lot of urbans who have health insurance, so they have choices. And so when I look at our clinic and I look at our billing that we have, about 40% of our patient population does not have health insurance. And so those are the people who IHS is taking care of with their funding. Because that's people who are like my mother. My mother retired from IHS, but she never had health insurance because IHS was always there. So, today she's like, that was a mistake. I should have taken health insurance so that I can be referred out. Now I'm getting sick. I mean, she's 83. So now she's starting to have illness, but she doesn't get referred out just because we do have a high patient population. Had she had health insurance, she would have been able to go out and be seen more quickly. Otherwise, she just had stents placed in her heart, and she had to wait over 6 months to have it done. And so she was passing on at her house. And luckily, I have a large family, and so I would have cousins who would stop by and check on her. So, when people are in an urban setting, they do have that choice of, okay, do I go to the urban health clinic, or do I go to Rush, or go to Advocate? And so for those who have health insurance, they have a lot more choice than people who have no insurance. And unfortunately, I think the statistics on my home reservation were over 60% of the people had no insurance. So, we're kind of the opposite here, where we have 60% we have health insurance, and 40% we do not. And those are the people who we try to make sure we try to take care of as best as we can. And how people said, one's providers have received their loan repayment, they're gone. It's very true. It's unfortunate, but a true statement. I come from an area where I was very fortunate. Our tribal leadership had foresight. And my father was one of the chairmen who started the INMED program, the Indians into Medicine program at the University of North Dakota, because they were having such a hard time recruiting providers that he said, why don't we grow our own? And he and some of the other tribal chairmen from North Dakota met with the university and set up an Indians into Medicine program in partnership with the Indian Health Service. And so the first graduates of that program retired last year.
Thank you, and thank you all of you for sharing. So the next question I'll ask, although I know that we're all exhausted of hearing about it, is I'm going to ask about the pandemic, but I think really across the board, especially prior to early vaccination, COVID was just really running rampant in our communities. Not because we didn't care, but because we're very tight-knit communities. We are living in multi-generational homes. But on the flip side of that, I think it was also a really strong example of tribal sovereignty and urban sovereignty, especially after vaccinations became available. We were able to, again, take those sovereign rights and say, no, we want to make sure that our cultural keepers, that our language speakers, these are the people that we're going to prioritize within our communities. So if, again, you can talk about the personal lessons from the pandemic as well as the professional ones for our Native communities, that would be great.
Okay, I'll start with this. Pandemic. Luckily, clinic was somewhat prepared for the onset of the pandemic. And some of that came through my experience of working in Alaska area. Alaska area had rolled out its telehealth program back in 2000. I know I'm dating myself, but that's fine. And I'm also retired from IHS, so that really is me. But it gave us the foresight to be able to roll out maintaining telehealth services. But as everyone has stated, American Indians, Alaska Natives were more adversely impacted by COVID than any other race, ethnicity, or group within the United States. We were more likely to walk away if we got COVID or be hospitalized in an ICU. We maintained at the clinic, we were given a choice. We either get our COVID vaccine from Indian Health Service or from the state of Illinois. It was my fault. I made the wrong call. I know IHS is usually last on the list, so I decided to go with the state of Illinois. However, the state COVID vaccine then was funneled to the counties, then to the city, and with the battle between the political groups, IHS actually rolled out their vaccines much faster than the state of Illinois. And so then we had to follow the city rule to keep receiving vaccines as far as how they were rolling out age categories. And trying to explain to the city of Chicago that an elder in a community is 55 plus was difficult. And I was also speaking with my counterpart, like colleagues at the Bemidji area at the time, and saying the city's not letting us roll it out, and they told me, well, Roxanne, we can switch you back over to IHS if we tell them anything. And so I went ahead and said, okay, we're vaccinating 55 plus, we're following our rule of what elders are. And so we really then started following the Indian Health Service as they were changing their categories. And so it helped, we also had a public health nurse who was going out to elders who were more homebound since the vaccines came out in winter time. And so they were able to go to the elders' homes and vaccinate them at their home and stay, monitor them, let them know to call the clinic if they started having any signs after they had left. And so we really tried hard, but another battle we were having was the stereotype of, do you trust this vaccine? And being with natives being guinea pigs, there was still a lot of distrust of the vaccine, and there still is.
That's how you take notes out. Sure.
Okay, so I didn't necessarily work in healthcare during or after, but I do have I've been able to kind of take a pulse of kind of the experience of Native physicians and kind of what's been going on with them. And So like, some of the things that have really stuck out to me is not necessarily before and after, but the during and what come out of that. Because, so like. Navajo Nation and the Seattle Indian Health Board, both reported, receiving body bags instead of some of the. Instead of some of the materials that actual healthcare materials that they asked for from the federal government. And that on top of all these other failings that like. From the federal government, it is just like compounded this problem that we have of for healthcare for natives. And so like after. So I went this recently to a conference for the Association of American Indian Physicians. And the conversation has changed a bit, in terms of. Yes, we need to like continue advocating for what is ours by treaty rights, in terms of healthcare funding and resource. But also we need to look more towards our own healthcare sovereignty. And what does that look like? What does it mean to like provide for our people and on our terms and with our own resources? Because ultimately, like our traditions and our ways are gonna be here longer than this interesting project that is called the United States. And we need to figure out how to best treat our people and how to maintain our health. With or without.
Yeah. So there are a couple things that I would like to add. Roxanne, I think you mentioned this kind of at the beginning, that the pandemic, and I think this was in the keynote, Tammy, the pandemic affected Native American communities in the most devastating way. And I hope I'm getting the stat right. I think since 2020, our life expectancy as Native people has gone down by about 7 years. A Native American person born today has a life expectancy of 65. Think about that for a second, and to think about what that means, how young that is. It's just the amount of language and culture keepers that have been lost in the pandemic. It has rippling effects and cultural devastation, not just that, it's about our people not surviving the pandemic, but it's about also what this has done to our communities as a whole. Juxtapose that with the way that Native tribes have come out in ways, that have been in support of the whole community's health, not just Native people. So I'm gonna give Cherokee Nation as an example. Cherokee Nation was offering vaccines to anyone in Cherokee territory, whether they were Native or not. They were rolling out vaccines. They had a whole mobile unit, like a giant Hard Rock casino in Tulsa, where anybody could pull up and just get a vaccine. And so I'm always struck by the statistics of how this has really affected our communities for generations to come. And despite that, Native communities themselves were taking steps to ensure everyone's health, not just their communities. So I just, wanted to add that. Yeah, I think Angela, do you have anything on that?
Yeah, I think Angela, you bring up a really good point. I mean, disease in our community is nothing new. Back to the 1600s, disease was used to decimate our communities. But regardless of that, we are still here. We continue to be here. So we talked about some kind of more of the topics, but they're important topics. So I was hoping that we can talk more about some of the innovative projects that are happening within Indian country as it relates to healthcare. There's a lot of great work being done with data sovereignty, really bringing back that indigenous brilliance that we are always have had with indigenous methodologies back to our native healthcare spaces. I'll kind of open the floor for this one, but if there's any project in particular that you either are involved in or you are looking at, and saying this is really great work that's being done in healthcare. you to share.
I think that one of the most impressive projects that I've seen in the past couple of years is the food sovereignty program. Because everyone forgets that food sovereignty really impacts health. It's like if you're eating foods that have been grown locally, if you're harvesting more traditional meats, if you're harvesting traditional rice, all of that traditional food is healthier for our people. And that's something that we as a community in Chicago need to really focus on, is being able to find a place where we could actually grow traditional foods, where we could actually find traditional meats, where we could find more of the traditional nutrition that we used to have. And I think that a lot of that is part of our huge diabetes problem, our cholesterol problem, our heart disease. All of that is due to foods that we are eating. You know, when the government started giving commodities and rations to tribes and reservations, you know, all of that impacted us negatively. When I think back to my grandparents who, you know, raised cattle and grew their own food, and they lived to both be 88, and they were relatively healthy until, you know, they passed away. And I have, you know, ancestors who were in their 90s and early 100s who had more traditional foods. And then when I contrast that with my parents' generation, where commodities then became more of a food staple, and on my mother's side, I have an uncle who lived past the age of 62. So you see that impact. You also see the impact of our diabetes rate increasing as we're having more modern food introduced into our diets. And so I think food sovereignty is one of the major improvements that I've seen that are very innovative and helping with our health and well-being.
Thank you.
So going back to this, concept of 638, so my tribe was one of the tribes that decided to 638 their healthcare. And it's been a long road. Like I said, when I was little, I never saw the same provider. It was always someone new. We had to go off the reservation to see someone. But I am really proud of my tribe because they've definitely taken on the healthcare sovereignty part. And I went back in August, and like they opened up, I think it's like an assisted living facility that they have on the reservation. It has 12 beds, and they're definitely making strides to you know, take on the ability to provide healthcare to our people, and also like other programs. Like my niece, who's 12, participates in like an after school program, summer program at Tortuga Ranch, and they, you know, they integrate, you know, traditional healing and, you know, therapy. And I think it's beautiful because like when I was her age, I definitely did not have that as an option. It was still very much a stigma of, am I, you know, I'm sad, but I have to keep that inside. I can't tell anyone, no one can know. So they're definitely doing things that I am very proud of. And when I'm done with my degrees, because this is step 1, DNP step 2, and I go back, I'm really looking forward to contributing to what they've already started and hopefully growing it.
So there are a number of things in sort of behavioral health realms in Native communities that I think are, they've been going on actually for a couple of decades, even though I would say in a mainstream way they're very innovative. I think that researchers who are Native researchers and allied researchers who have been partnering with community through methods like community-based participatory research or participatory action research for a couple of decades have seen how communities have the ability to know what is best for their people. And, they have the ability to work with researchers who can lift up the community strengths with community, build capacity, things like that. A couple examples of what these projects look like. There are 3 hubs that come to mind. Johns Hopkins is one. The University of Washington has an Indigenous Wellness Research Institute. And in Denver, there's a Native Children's Research Exchange. All of these groups I have been very fortunate to be part of as a researcher and continue to, maintain my connections to those groups. And all 3 of those have very long funded, federally funded research projects that are partnering with community. Johns Hopkins has a Family Spirit Program, which is a maternal and child health program, and I think talk about, seeing our patient population as like a whole person. That program utilizes a home health model that has shown to be very effective in increasing positive outcomes for families and children. And another example that I think is quite innovative comes from the Indigenous Wellness Research Institute. Karina Walters, who's in Choctaw, has been PI of a project that has worked with Choctaw Nation to rewalk physically pieces of the Trail of Tears that tribal community was forced to walk in the 1800s, and uses that as a way to help Choctaw Nation members reconnect with cultural teachings and language, to then become helpers in their community, where they have revived for this project their traditional clan structure as a way to organize how community members who participate in this program understand their roles once they return to community. All of these things are projects, again, that are not new, but I think are projects that mainstream research and healthcare could learn a lot from. And certainly they're innovative in that way.
Yeah, as Angela said, like a lot of the innovations that we're seeing are not actually like innovations for Native communities. They're rather a return to a lot of our original, values. Like one of some of the things that programs that I've seen like really inspiring that have come out since the pandemic have been like mutual aid groups, like the Navajo Hopi Mutual Aid, in which they provided like both food and various forms of healthcare during the pandemic to a lot of these communities that were pretty much outside the reach of IHS. And I mean, mutual aid, that's kind of like a hot term right now, but like we've always had like principles of mutual aid within our traditional health system as Native people.
Thank you. So the next question I'll ask, and I actually might ask the principal and Alex to start thinking on the future healthcare practitioners, but what do you imagine and hope for the future of Native healthcare? And in addition to that, how can non-Native people, whether it's the people in this room, the people on Zoom, the people that watch this recording, how can they support that future vision? Or do you have like, I have no idea, our trailblazer who we have. You can not see.
Okay, I'll try. So, what I hope to see and what I hope to work for is indeed like health sovereignty, and like again, like the US owes us rent, and part of that rent is healthcare and healthcare resources and funding for that. And but like also I'm looking forward to a future in which we are able to maintain our own health and maintain it within our own values. And that's what I kind of work towards. And for people who want to help with Native health, I guess my thing is to educate yourselves. Because I've found, even as a medical student, I am doing a lot of the heavy lifting in teaching administrators or whatever, like what it means to be native and what it means to like, and what native health means. And all this knowledge that I've obtained didn't come from me just being inherently Hopi. Like what I learned from being Hopi was like the stories that like my family has, their interactions with the healthcare system and such, but like my understanding of our health disparities in our communities and our history and the state of Native American health today, that came from my own mental resource and taking time to look into it. And well, yeah, I just want to be able to treat patients without having to explain to white people like why why like native health is the way that it is.
For me, what I'd like to see, once I reach the end is there's so much beauty in native healthcare and indigenous healthcare and like so many positives. We spend a lot of time looking at like all the things that have gone wrong, our diabetes rates, which is also very important to look at. But we've also done a lot of things very successfully, and that gets overshadowed by by other things. And so I'm hoping to as I go, like show people that there are things we have done well, successfully, and that they can learn from us. And for other future healthcare providers or those that are still there, like stay humble. It is great to have an education, and I'm privileged to be sitting here and going through this, but I have cousins who never went, who haven't done this, who never went to college, some who haven't graduated high school, and they still have so much more knowledge than I do. And keep that in mind, like your degree, it's great, it's beautiful, but the person you're treating also has a wealth of knowledge for which does not exist a degree. So stay humble and open to listening to other people as a teacher.
Thank you, Crystal. Yeah, and then Rob and then Angela, I know that you guys have been doing amazing work, and I'm sure that you're going to retire at some point because you deserve it. So when you pass this on to the next generation, what do you rough things, right?
I'm ready. And I don't know if you know, I'm on the board of directors from GUI. And so one of our big pushes during the pandemic, pre-pandemic, was full funding for the Indian Health Service. Greater funding for urban Indian health programs. When you look at the IHS budget and you know that urban programs only receive 1% of IHS's funding, imagine what we could do if we were fully funded. During the pandemic, one of the biggest issues we had retaining staff was, who am I to compete with Rush, who's offering a $20,000 signing bonus? I don't have that kind of funding. And so we really have to pull people who want to learn, who want to serve an underserved community, and getting people who are there for more than just their loan repayment fund. And so getting people who have that connection to our community, who want to maintain ties with our community is critical. But other than full funding, one thing that was brought up earlier is decolonization of dam. I would love for that to happen. When we worked with the city, we maintained all of our COVID data. We submitted all of our positives, how many people we tested, and we did test everyone who came through our doors. But we natives, first responders were our highest priority because we knew that they were out there. This is our community. So when a reporter from Northwestern was interviewing the city stated that they had no data to show on American Indians and Los Angeles. My clinic had a contract with the city of Chicago to have 2 contact tracers within our clinic. I'm like, so where's our data going? And so it's like, we always hear that we're marginally insignificant. And that term has to end. And so I would hope for that in the future, that the term marginally insignificant is no longer there, that native is often on the ones. And you always hear me use the term there, thinking, you know, Alaska Native, I use that just because that's who the treaties were made with. And so that's the term that, you know, we still utilize within the Indian Health Service, and it's a lot of federal grounds. So that's why I still use that term. But so decolonization of data is one of the big things. And, you know, you still have, you know, that something else box. We're not something else. I'm an Anishinaabe. I'm sorry. I'm not an indigenous creature. I'm an Anishinaabe. And so we do count, we do matter. Keep track of our data, you know, with COVID, it's like, what was the true impact? How many people were missing in a home? You know, because a lot of people will simply look at you and check. I don't know how many times I've personally corrected people and told them, I'm not Hispanic. I'm American Indian. Please correct that. And they tell me there's not an option, this there should be an option. And so that's something that I would love to see as part of the future. And another thing I'd love to see is something beyond land acknowledgements. Land acknowledgements are a nice piece of paper. They don't do anything. You know, universities putting out land acknowledgements like running water. Where are my scholarships? Where are my native students? Where is the next generation coming from? You know, when I went to school, my student loans were not, I had $8,000 in student loans when I finished law school. Today's students, $8,000 barely covers their books for a year. Especially in health. And I know that just because my daughter's education. You know, it's not practical anymore. We need to have people who sign a land acknowledgement, help put money aside to develop our future leaders. You know, when I look at these two young people, I'm excited because yes, I am. I'm a little bit harder for my retirement.
Thank you. As a future elder in training, you know, I just, so many of the things that Roxanne, you said, touch on the pieces that for me are at the core of all of this. So, you know, the lack of representation in higher ed spaces for Native people is pretty astounding. And I can't remember if I said this already, but there's a psychological concept about the impact of invisibility. And one of the ways to understand invisibility is absolute invisibility, where when your group is not portrayed or depicted at all in a setting, that in and of itself is a message about your group. And when you think about how that plays out in, for example, higher ed spaces, that's a big deal. If you don't have those role models, if that's not something that's depicted and available to you in a real way, that there are faculty, for example, at these institutions that are training the next generation that are Native. That is a huge deal for not only recruiting, but retaining and supporting adequately Native students. You know, like I said, Native students experienced the highest dropout rate of any group during the pandemic. And so I think there were already barriers for Native folks attaining higher education, and this just compounded that. It is so important for training institutions and universities to not, like you said, Roxanne, just acknowledge, but acknowledge as we have created a campaign that lives on diversity's website. Acknowledge is a verb. It's a thing you do. It's not a thing that you read. It's not, you know, deeply, it is engagement, it's process, it's bringing community in and valuing their expertise, it's listening to them. It's implementing the things that they tell you that their children need. Native communities do prioritize education. That's very evident in how Native communities financially will support their children in pursuing higher education. Cherokee Nation, for example, has scholarships available for Cherokee students who want to pursue higher education. Some tribes offer thousands and thousands, to cover some of those major costs that they know that their children are not going to be able to cover without loans. This is a priority for Native communities. And we need, institutions to meet that. Recognize the obligations of, for example, being a land grant institution. Where did that land come from? Who paid the price for that? It was the Native people. And really putting those policies in place, that's what's important. So I just want to lift up what my fellow panelists already said so well. That it's about putting things in motion, to actually support Native folks in coming into and successfully finishing their degree programs. Thank you all so much. As we close out, if there are people in the audience, there is no cards on your tables. If you have a question that you would like the panelists to answer, and people online, you can put it in the chat. But the last question that I'll ask you, we've talked about a lot of things: food sovereignty, data sovereignty, decolonization. If in a sentence, which is probably going to be hard, if you were going to give one piece of advice to someone who knows nothing about how to support the health of Native people, what would it be?
You're making a choice now. I would request, anyone who's interested in Native health and uplifting Native health to be an advocate on behalf of natives to your local, state, and federal representatives. We need both funding and as part of that, though, listen. Listen to what Native people say they need, they want. It's not what your interpretation is, it's what the Native population's interpretation is of what is needed and what they would like. And so that's my spiel is please go out, advocate, write your Senate, tell them that we need full funding and also ICWA, support ICWA. If the Supreme Court rules and says that ICWA is racially based, it isn't. We were classified. This is government relationship. It's a political category, not racial. And I'm hoping that the Supreme Court makes the right decision. But if they don't, we're going to have federal enactment of laws to protect Native children so that Native children aren't taken away from Native parents beyond like they were in Golden School there. Thank you.
Let's see.
Lot of things.
I think I'll say this, and this goes for any cause. But I apply this to myself, when trying to stand in solidarity with other people. But I don't really fully feel, I don't fully see you as an ally or an advocate until your advocacy has made you uncomfortable.
Thank you.
So mine would also be listen, we're not monolithic. There are 4 of us up here and we have very diverse backgrounds between the 4 of us. So anything you learned from like a Disney movie, was probably very, very, very accurate.
Okay, there's a fact that I want people to keep in mind here. So there was a recent national study conducted by a group that included Stephanie Freiberg, who has done a lot of work on representation of Native people. this national survey asked non-native people a lot of questions. But one of the things I want to highlight is that 62% of the respondents indicated that they had never met a native person in their life. First of all, that's probably not true. You know, they probably didn't realize if they had met a native person, because that person may not have looked like the common misperception that we look like Disney characters. And that is key for a few reasons. If 62% of the US population that's outside of your group says that they've never met anyone from your group, and yet they still get to vote on legislation that affects just you. Think about what that means. This study also duplicated, I know, now more than a sentence. This study looked at lawmakers, so people who at the federal level are creating and voting on laws. And found similar trends, that those folks were similarly not really well versed in native issues. So you can see how this begins to really heavily shape how native policy is made. Now you can see the connection between those statistics and the percentage of the health budget for Indian health that is dedicated, for example, to urban communities. Now that 1% makes a lot of sense. If you don't think that native people live in cities, why would you think that you would want to allocate a budget for their healthcare? So that whole preamble is to offer one sentence, which is that question what you know and find better resources for information. Recognize that you have been bombarded your entire life with images and messages about Native people that are inaccurate. And it's on all of us to question that and to do better and learn better and to learn from Native people.
Thank you all so much. So the audience questions that we have are both related to each other. So in our last 3 minutes together, most of the audience here and on Zoom is with the UIC health science colleges. What can colleges do better or differently to recruit Native students to their college profession? And then to add on to that, to retain them. First of all, I don't know if you want to start first, as current UIC students who were recruited and we hope to retain.
Yeah, so I mean, but I mean, so like, there are good steps in that, like, Winter College of Medicine now has in-state tuition for Native American medical students. But I don't know of any medical students who are, that they've given that out to. And so that speaks to both our recruitment and like, and I put a lot of mental resource into trying to advocate for that, and it took a lot for me. And as a med student, you're hella busy, and like you really don't have time for that kind of stuff. So it's beholden onto the colleges, to these administrators and these deans, to be the ones allocating resource and time for these causes. It should be the deans who are and the administrators who are pushing for administration. And for admins, med students being admitted, and let the students be students.
Crystal, do you have anything to add?
So my first semester, so I still, the other thing went, so they have a couple. Yeah, definitely financial support. I got 0 scholarships through UIC. Nursing school is, it is not cheap at all. So, you know, maybe work towards that. Two, I can see my professors trying to represent us somehow. Like, I have one class where they threw in a paper on, I don't even remember what it was, because it was like 15 papers we had to read for one module, and it got kind of overshadowed, but it was on Native American population. And I probably would have been more work for me, but I gladly would have like offered them some alternative pieces, because it was very much from an outsider writing about Native communities. And I icked the whole time I read it. So there's that. And if there were an option, I kind of, so I'm doing the nursing and I'm doing my NPH in Indigenous Health. I'm very grateful that I'm doing that. It's a lot of work. I'm exhausted. I'm also working full time because nursing is expensive. For me, that's kind of it's keeping me grounded, having that second bit of knowledge. Going through my nursing career, so I know it's not an option here, but if there were a way to give students those extra courses, if they want that, it's more work. Not fun to have more work. I enjoy it, but I'm crazy. Yeah, I think just having a way for us to like integrate ourselves in what we're learning would be nice. I don't know how you do that aside from taking out your own program, but I don't know, I'm here for at least really we can talk about it, we can have those discussions, and, you know, DNP, if I get into that, then it's really curious from, in that,
Angela, I don't know if you wanna, particularly, I mean, if somebody who can add there right now. Yeah. Well, there are a couple things. I think that we, as an institution, can learn a lot from some of the movements that are happening across the United States with universities and how they are supporting Native students in particular with tuition waivers, and additional kinds of support. So that's one thing that I would love for us to continue to move forward. And at the same time, I think what's evident in the comments that you made out in particular is that we need to make sure that there's the infrastructure to put those things actually into motion. And in addition to that, to me, again, it comes back to presence, Native people being present in these spaces. So that means we need to hire Native faculty. Institutions need to hire Native faculty, Native staff, and make efforts to include community in decision-making and in programming. There's some really innovative examples out there of all kinds. I'm thinking of a program that I was made aware of recently in Oregon, where all pre-med students who graduate with their bachelor's who are Native are guaranteed basically the ability to have a job at the institution at their university until they get into that school. The Dean of Applied Sciences, we got that one. It sounds like a really interesting model. And so I would love for us as an institution to make movement in that way. So, but again, I think it's all about bringing in community and bringing in faculty. So all of. Thank you all so much. So we are now at a close. I just want to say, thank you all so much. I am honored to be doing my education with amazing people like Alex and Crystal. It makes me hopeful that the healthcare space has people to take on the amazing work. And Angela and Roxanne, I'm privileged to follow your footsteps and to learn about all the amazing work that you have done. It really is an honor. So with that, I'll go around with like much.
You didn't want to.
I know all of them.
Can we do a quick group photo?
Sure.
Thank you.
Yeah, and then I